I'd like to begin by welcoming everyone here. My name is Tamara Giles-Vernick. I'm the coordinator of the SONAR Global Consortium, which is a European Commission funded consortium with 15 partners around the world, devoted to the preparation or preparedness and response to epidemics and antimicrobial resistance. So we're really excited to be with you today and to share some of the results from 5 countries where our vulnerability assessment tool was carried out and where multi-sectoral, multi-scalar community engagement is ongoing and will continue into 2021. So just for logistical purposes, you'll notice that your mics have been turned off. What we would ask you to do is to put your questions, either of individual speakers or any cross-cutting questions, into the text box. Now, with that, what I'd like to do is to introduce Anna Volkman, who will be speaking to you about the overall approach, theory, and methodology. Thanks very much, and we're really looking forward to the next couple of hours with
you. So, thank you so much, Tamara. I'm very excited to be here today. It's going to be, I think, a very interesting session. And I've been tasked to give a little bit of a framework, start with some of the theoretical and methodological considerations around vulnerability assessments before we hear from our country partners. So with that, I will get started. Before we dive in, I just want to reflect on our definitions of vulnerability. I think it's very important to consider that the term can very much be an ill-defined black box. There are very different approaches that people take to understanding vulnerabilities, different people, different meanings. We have, depending on the academic sector or the research angle that someone might take, we look at biological or physiological vulnerabilities. So, for example, risk factors for diabetes, or somebody might talk about emotional and psychological vulnerability. For example, when we consider young age or people living with mental health impairments in our, for example, ethics approvals and so forth. Or we talk about socioeconomic vulnerability, for example, those who are isolated socially or who are financially disadvantaged. And then, of course, something that we're dealing with as anthropologists, what might be termed cultural vulnerability, for example, those who live with what are considered non-normative habits or customs. So I wanted to quickly point out that, of course, vulnerability is always a matter of linguistics as well. We have presentations from 5 different European countries today with many different languages spoken by the participants. And so the term itself can be complicated. It can be literally not translatable. And so we use the term really as a tool at this point so that we can anchor our work around it. But there are, of course, many concepts of vulnerability. Just want to give you a quick taste of that. This is a great publication from a few years ago that actually shows the many different approaches that can be taken, and I won't dwell on this any further, but wanted to highlight very briefly that the term really originated or became more prevalent around in the 70s in the context of disaster and emergency aid and humanitarian interventions. We can agree on a couple of things when it comes to vulnerability. For example, risk is at the heart of the concept of vulnerability. So, for example, how systems, communities, and individuals react to and deal with risk. Vulnerability is not absolute, but it's a matter of degrees. Degrees of vulnerability are produced by the presence or absence of certain factors, some of which we will hear about today, and the interaction between those factors and the coping capacities of affected individuals, households, or communities. So vulnerability is cumulative, often over the life course, or at least over a certain period of time. And again, this is something that we will hear, of course, more about today. The concept itself may be also used similarly to notions of need or susceptibility to harm or neglect, or lacking durability or capability. And I want to just quote one definition by the World Health Organization, because it has bearing on how we move forward with this, which defines specific groups, vulnerable groups, in concrete terms. So, for example, children, pregnant women, elderly people, and those people are characterized as vulnerable. The reason I'm mentioning that is because there is a danger when we talk about vulnerable people as a fixed population, that we turn it into something that has notions of pure passive need, or a person in need. And the provider of that, or someone who can alleviate that need, is crucial and the key to actually enabling people. However, we want to emphasize, and of course it comes forward in our presentations, that needs are always complex. They, as are the sources and also the drivers of resilience, somewhat of the other end of the spectrum of vulnerability. And providers of assistance and support can often take unexpected forms. And this is something I think that we'll be very interested to learn more about when it comes to the research section of this. And I wanted to just kind of put one little side note in here, because we're of course talking about health vulnerability in the context of our presentation today, and we have this understanding in our working group that health is something that is largely created outside of the health sector. And there's a little graphic here that gives a bit of calculations around how much time we actually spend on our own versus in a doctor's office or with a medical professional. So when we talk about vulnerability, and as I said, we consider health to be something that is largely considered outside of the health sector. And so we think we take into account all of these different factors that come into play, that create, that amplify, or that reduce vulnerability. And so we often think about it as something that occurs on a spectrum. And so there are certain factors that can push people further to the left, in this case, where we have placed the resilience, where they are more resilient, or to the right, where they become more vulnerable. And so when we look at how to conceptualize vulnerability in the context of a working group, we currently define it as being in a situation over a meaningful period of time in which a distinct set of cultural, social, and biological risk factors, we may very well add others like geographical, political, psychological, and so forth, factors come together to make it more likely than not that a person experiences ill health. And one of the outcomes we hope to have from this is, of course, maybe redefinition of that. When we work with this idea, how then do we actually identify those factors while also understanding their compounding effects, and then take into account resilience at the same time? And so when we look at research methods that might aid us with this, we have certain key requirements. So when we developed the protocol for vulnerability assessments at UCL, we had a key requirement, and that was we wanted to elevate what we call the lived experience to the level of evidence. In other words, find ways of actually qualifying people's experiences and then elevating that to a level of evidence. So importantly, we knew there would be qualitative components, so we can establish a baseline, identify unknown data, and capture data that cannot well be communicated, perhaps, for example, through research questionnaires. It should be a rapid assessment, which should enable contemporaneous analysis if possible. It should be iterative. This is very important to people who work in the social sciences. So insights that are gained at various stages of data collection are actually feeding into the process. And then, of course, we want things to be scalable, replicable, and transparent. And key points here, they should be actionable. Any research that we want to do should be focusing on actual interventions and actions. So the aims and of our vulnerability assessments really are, and this is something that I'm putting as a preamble to the presentations that follow, because these same aims were shared across all of the partner groups. They should identify local factors that reduce or augment health vulnerabilities. They should develop case definitions of vulnerability and resilience. They should allow us to extrapolate from participant cohorts to the wider population. So where that's possible, we want to scale up. and they should suggest locally meaningful actions and interventions. Again, coming back to my previous slide. So importantly, we want to ensure that if we implement a global research protocol, a global data collection and analysis protocol, that the local needs and priorities are taken into account, and that the global protocol is meaningfully adapted to local conditions and needs and priorities. So when we are implementing these kind of global research protocols, we of course need to start somewhere. And again, I want to stress this because it will clarify some of the procedures that our partners used in their individual studies. They're implemented in a initially predefined cohort based on what is known locally. And then we have a significant proportion of participants that are actually ideally recruited through snowball sampling based on their specific vulnerability or resilience patterns that are reported by other participants. So again, coming back, there's an iterative recruitment process here, which is really important to us. We also really emphasize stakeholder engagement. We want to, of course, include them in the pre-definitions of vulnerability or of participant recruitment criteria. And we want to select a percentage of our participant cohorts based on those characteristics that are also brought forward by stakeholders. And again, those things are usually adjusted throughout data collection period. So for this particular study, the research sites were chosen to contrast between certain participant characteristics and again, based on local knowledge and prior research to reflect, in most cases, urban and rural divide. So very briefly want to talk to you about what it actually entailed, the global research protocol. Again, this is what happened at all of our partners' sites. They started each assessment with demographic survey questions, and that was then followed with ethnographic observations that were summarized in field templates. And the core of the assessment, of course, is an interview protocol. It's a very extensive and in-depth protocol that is field administered, and it's something that I wanted to commend and applaud our partners for, because under extremely trying circumstances, they actually went out into the field. In most cases, there were some assessments collected online, but a vast majority done during lockdowns with severe restrictions in place. So that was extremely impressive, and of course contributes to the quality of the data that they have obtained. So the interview protocol focuses on three, what we call domains of inquiry. And I won't go into too much detail, but roughly the first domain looks at what formal scenarios are in place, what local support is there for people that they have access to that they can use. The second one looks at community domain. In other words, what do neighborhoods look like? What do communities look like? How do they respond to, in our case, the COVID challenge? And then the last one looks at the vulnerability domain, which examines in quite a lot of detail individual and community vulnerability. And I just want to very quickly summarize our data analysis and outcomes process. So we have, of course, a collection of assessments that are then coded and analyzed following a very specific protocol. And those elicit main themes, which are then converted into local vulnerability factors and ultimately into complex case definitions of vulnerability, which can also be mapped onto existing epidemiological data. And of course, what we hope to obtain, and I think what we have obtained, are nuanced and informative findings to inform local action. And I think with that, I will finish here and hand over to Professor Ursula Lipovic-Sebron, who will talk about her assessments in Slovenia.
Thank you, Anna. Thank you, yes, for this wonderful presentation. I would like to present vulnerability assessment in Slovenia. Just some very quick COVID-19 related events in Slovenia. On March 3rd, there was first COVID case confirmed in Slovenia, and later on 12th March, epidemic is declared. On March 13, new government takes power, and new Prime Minister is Janez Janša. Quite important is the fact that the heads of the main institutions are replaced, including those involved in epidemic management. And from 28 February, a series of anti-government protests
were taking place and are still going on. Right now, we have quite numerous cases in Slovenia. Yesterday's statistic is as you see, 400,000 people are infected, and died 5,001 person. On November 7th, Slovenia has the most daily new confirmed cases per million inhabitants in the world. And with the next slide, you can see our research location. We chose 2 locations, the capital, Ljubljana, which is also the center, economic, educational, political, and administrative center of the country with high living cost. And the other location is Murska Sobota, near the Hungarian border. We chose this location because this is quite a socially and economically disadvantaged area. It's a border region and is a bilingual territory with large Roma community and also difficult transportation links to the other centers of the country. Right? And here are our participants, just 2 essential figures. We have 214 vulnerability assessments we conducted in last month. The gender, you can see they were, the majority were women, and we have 6 age groups. The majority or the most numerous groups were from 21 years till 50 years. Next slide, please. You can see here just some of the vulnerabilities. There were so many, and as already Anna said before, we in a way included psychological, biological, economic, socio-economic, cultural vulnerabilities. And the most important finding, the first most important finding in our research is that we witnessed this huge and very complex intersection of vulnerabilities. We were not able to interpret our material on the basis of vulnerable groups in this concept of a static, rigid idea of vulnerable groups, but as intertwining of these bubbles, as you can see here, of different and very complex vulnerabilities. Here we can see just 2 cases. First is a single mother from Ljubljana who is living in poor household with a lot of mold, and she's a precarious worker. She has a lot of financial insecurities, and because of COVID measures, she couldn't work. She couldn't travel due to these restrictions. So she is in even more difficult position, also not only economically but also psychologically. The other case is a woman. She's Roma ethnicity, living in Roma community near Murska Sobota. She is living in poor housing condition. She's having severe mental health issues, and at the same time she's victim this is a result of domestic violence. She's also disabled and elderly. So as you can see here, we are having a lot of complex and very intertwining vulnerabilities. So our first policy recommendation is to move beyond the concept of vulnerability group. So we believe that policies should be based on a more complex understanding of intersection of vulnerabilities, more connected to lived experience of people, not on abstract concept of what of vulnerable groups. Second finding is that most of the identified vulnerabilities are not a result of epidemic itself, but of epidemic management. We witness in Slovenia measures. They are mostly drawn up without consulting the experts. So mostly they are epidemiologists who couldn't be in a way those who were actually planning and then implementing the measures. Also, many relevant stakeholders were excluded from planning and implementing. What was a big problem for our participants were these ad hoc measures. They told us in many cases that they witnessed lack of coherent, transparent planning, and we could see in the material that these inconsistent and uncoordinated changes were particularly problematic for vulnerable people. Moreover, official communication was also a big problem for our interlocutors. They said that this communication was mostly grounded in the rhetoric of fear and not trust. So our policy recommendations are that it's necessary to clearly differentiate between the vulnerabilities caused by epidemic itself and those caused by measures. So also the strategy for epidemic management should be more comprehensive and inclusive. And should involve representatives of various different stakeholders, NGOs, unions, and also representatives of vulnerable populations. But very important is to involve epidemiologists and other people, professionals in the field of epidemics. So also the communication with the public should be based on trust and respect. Should focus on solidarity building, community building, and inclusiveness is what our interlocutors are emphasizing. The third finding is that the measures are more demanding of people not fitting the mold. So what our material says is that it was clear for our interlocutors that the strategy for the control of COVID-19 was created top-down, and has a particular, and we could say that there was a particular model that was created for, such as nuclear family, middle to upper class, with people with stable employment and housing conditions, and that were Slovene nationals. So it was much harder or impossible to respect the measures for those who are not fitting into this presumed ideal model, such as single parents, for example, the case I was talking about, single mother from Ljubljana, or for example, precarious workers, or people, many of our interlocutors who have precarious legal status or are without any legal status. For example, asylum seekers who are living in asylum reception centers. And for example, for those who don't understand or speak Slovene, it was quite clear that many measures, many information about COVID was only in Slovene language. So it was not accessible for those who don't speak this language. So for us, quite important policy recommendation would be that the measures should take into account the heterogeneous population and diversity. The fourth finding is that, of course, COVID-19 and the epidemics, as well as the measures, exacerbated pre-existing vulnerabilities. So one of most important findings was that public services that were already before difficult to access were now practically, in many cases, inaccessible. Also, public places were many times inaccessible for our interlocutors. Total institutions who are widespread around Slovenia and were already before crowded with people and have lack of professionals working there, became a hotspot for infection. And in these institutions, for example, prisons, psychiatry clinics, or homes, nursing homes, we could witness through our interlocutors that they were deprived of contacts with outside society and decrease their quality of life. Another thing very important is the lack of adequate and accessible housing. That was a big problem also before, and now during the epidemics was even more important, this problem. So our policy recommendation are to encourage and enable decentralization, improve accessibility of public institutions and services, and very important to empower or understand how important is not to privatize healthcare institutions, how important is to have accessible public health. And the last findings, there were many new vulnerabilities during COVID pandemic that we came across. Just one of them is so-called, one of our interlocutor said that it's COVID syndrome, but we could witness this same syndrome in other interviews. We could say that this is a complex intertwining of anxieties that are not only psychological, but also social, economically, and environmentally based. So this syndrome or this complex situation is especially present among younger population. We could also see that there are numerous interlocutors that are expressing pessimism and lack of vision for the future. So our recommendations here are that social scientists should be involved in strategy making and implementation of epidemic control measures, as well as politics of recovery and resilience. So it's important, especially for these new unexpected vulnerabilities, to really we should think of different way of researching, and where qualitative and not only quantitative research should have an important role. So just to finish, our so main policy recommendations are that we should pay attention to intersections of vulnerabilities. We should move beyond the concept of vulnerability group. It's necessary to differentiate between the vulnerabilities caused by epidemics itself and those caused by measures, and that the measures should take into account the heterogeneous population and diversity, and we should encourage decentralization and improve accessibility of public institutions and services, and that social scientists should be involved in strategy making and implementation of the measures. So I would like to announce the next speaker, Jean-Paul Baldacchino from Malta.
So I'd like to thank you all for listening in, and what I will do is try to give a brief overview of the findings from the Malta side of the project. And to jump straight in. So as a brief background, Malta is quite a small state with a population of around 500,000. And as a background to the progression of the pandemic, as of November 2021, Malta registered a total of over 38,000 confirmed positive cases. That's equivalent to 0.07 of the population, and 462 deaths. And comparatively, if you look at the statistics of our closest European neighbor, Italy, we have a comparable rate of positive cases, but a much lower mortality rate. The pandemic had a strong impact on key sectors in the economy, particularly tourism, aviation, and the service industry, which are important sectors in the Maltese economy. And as a background, the first case was recorded in Malta on the 6th March, and by the 26th March, government issued emergency measures, which is the legal notice on vulnerability, which I'll speak about this later in my presentation. And by the 30th March, we had 76 confirmed COVID cases in the first month. By 20th April, 4,700 foreign nationals repatriated, and 500 third country nationals had visas revoked by the 6th of May. By May 2021, however, Malta achieved herd immunity, and to date, 82% of the population has been fully vaccinated, so it has one of the highest vaccine uptake rates. Trust in medical authorities. During the part of what's important about this is also how people experienced the pandemic. There was a daily briefing, so the first few months of the pandemic, by the Superintendent of Public Health, Professor Charmaine Gauci, who gave daily press briefings on the progression of the pandemic and the daily numbers, to the extent that people identified with her, especially in the beginning of the pandemic, as a figure of trust, and it had even sort of lampoons where she was superimposed on an image of the Virgin Mary as a figure of somebody who can pray for us and save us from this pandemic. And Malta is a very sort of Catholic country, so the Catholic imagery and the maternal conceptions of care were still prevalent in people's understandings of well-being. But in terms of the actual numbers of data we've gathered, we had about 110 interviews collected, and they were collected from all over the islands of Malta from various socioeconomic contexts, with representing wide variety of categories of vulnerability. Over 54% of our people interviewed reported suffering from a chronic condition. In order to help access some of these populations, we also forged key partnerships with various stakeholders involved in elderly care homes, mental health care providers, victims of domestic violence, LGBTQI community, and asylum seekers, among others. Now, this is important because we don't claim that the study is representative. However, it's important to keep in mind that these populations do cover large sectors of Malta. In 2020, we had over 120,000 people living with mental disorders. This is according to the WHO statistics in 2020. 2019 shows that we had 1,325 reports of domestic abuse, and we know that about 80% of the cases of domestic abuse don't get reported, so the figure is even higher. In 2020, we had 2,221 people rescued at sea and disembarked in Malta, and as of 2020, still more than 3,000 people are living in reception centers. And we have around 5,312 elderly living in residential care facilities. So when you consider all of these populations together, you realize that we're not dealing with simply a minority of the Maltese population, but actually a significant number of people living in Malta could be classified as vulnerable in this regard, or potentially vulnerable. The gender distribution, we had a roughly slightly more female than male interviewed, with a large majority of our population being interviewed being between the 26 to 35 age bracket, but we've also had a significant number of people above 65%, 65 years of age. The income distribution of the people we've interviewed. You will see that a lot of the people we have interviewed across a variety of income brackets, but the largest number of people interviewed fell under the 0 to 9,000 euros annual income, which corresponds to what would be considered statistically as considered at risk of poverty in terms of Maltese income calculations, which on a national average, 17.1% of the population earns below 9K and is considered to be at risk of poverty. And these are, in fact, overrepresented in this regard in our sample, what was important to get access to these populations. So also as a additional point on the vulnerabilities, interestingly enough, the pandemic has also led to or affected other health-related statistics. In 2018, the ECDC noted that Malta has one of the highest rates, of syphilis in Europe. And as a result of the pandemic in 2021, the rates were increased, and this led to sort of a societal response, mainly through potentially minor outbreaks from sex parties, swinger parties, or so-called chemsex parties, when the restrictions were lifted. Key findings from the study itself. So what I will do is I will mention some of these key findings and then interpose them with some of the quotes from our own participants, which give, I think, an important context to the experiences that people went through. So many interviewees reported the reluctance to access essential medical services due to fear of getting COVID. So while on the whole there seems to be quite a large number of our people interviewed who were compliant, some were in a way overly compliant and went against the medical advice because they were afraid of going to hospital because they might get infected. And so this obviously led to further complications. And we had instances where the health authorities had to come out and urge people to come to hospital if they need to, since people were not coming, even though they had conditions which needed to be seen to. And you have a couple of examples over here. A 39-year-old female who reported problems with her father, who did not want to go in, even though he had heart conditions which needed to be checked, because he felt that if I go in, I won't come out. Interestingly enough, some people also reported the notion that quarantine itself, when people were placed under quarantine, they were afraid because of the stigma that's generated. So you have here a 25-year-old female lab technician suffering from multiple sclerosis herself, who notes when we had the first case, people would be like, oh, she has COVID and she deserves it because she went here or there or wherever. Those are the things that people are afraid of. I think being stuck in quarantine and the social stigma that comes with it, I think that's what people are afraid of. So this is an interesting insight into the effects of the measures taken. Secondly, we found that non-Maltese nationals who were already in a financially precarious position found themselves even further isolated, partly through the lack of social networks and difficulty in accessing health, welfare, or other kinds of state assistance. So here is a stakeholder who deals with populations who are also vulnerable herself. And she reported that she had a lot of people come seeking help because they've lost their jobs due to the shutdowns in the catering and hotel industry, for example, and found themselves without an income. When it came to looking at people's attitudes to health, it was interesting to note that people prioritized the individual responsibility for health. They're suggesting that health is the responsibility of an individual's willpower, goal setting, having a positive outlook. But this also means that potentially becoming unhealthy is considered to be an individual failure. You make the choices if you want to eat healthy or unhealthy, says a 23-year-old female learning support assistant. It's up to you. If you want to work out, you'll find time to work out. You just have to make sure not to be tired so that you have the strength. Otherwise, it's your own choice. A 74-year-old Jimmy, care home resident. Understand this, you are responsible for your own health, but many of them will say, if you don't give me sauce, if you don't give me any joy in my food, what's left in life? And they usually respond, well, what do you do? What do you want to happen? You want to be in pain? At least die with dignity without pain. Close my eyes and just go, not die with all that suffering. I wouldn't want to end up bedridden, unable to go out of the bed and covered in bed sores and dependent on medications, especially since nowadays, and this is important, there are so many awareness campaigns and people have no excuse about not knowing what they're supposed to do to take care of themselves. So the idea that health is an individual responsibility and that there are campaigns and information resources available, but health also being reduced to a fact of exercising and healthy diet, not considering other factors. Elderly populations also reported difficulties in navigating information, including health-related, and a greater feeling of isolation given the reliance on technology to communicate with others during lockdown. So the importance of having digital literacy among elderly populations was highlighted, particularly when they were experiencing isolation. We also noted that people spoke about a lack of coordination among support initiatives, and this has led to people not necessarily knowing that resources are available. There were many resources available, but people didn't necessarily know about them. But now to speak about vulnerability in three different senses. We speak of vulnerability in the first sense as a medical, but also legal category, particularly in the case of Malta. Medical vulnerability indicates likelihood of worse outcome and mortality rates, which is mostly related to biological factors, even though environmental factors are particularly important. But also vulnerability becomes a legal category, as we saw happen in the cases of the pandemic. In Malta, a legal notice was issued defining vulnerability as a category, and no vulnerable persons became a legally recognized category. And these people were ordered to remain segregated in their residence. And these corresponded to the known categories of medical vulnerability. So legal and medical definitions went together. But as my colleagues spoke in preceding presentations, you also have socioeconomic vulnerabilities. Now, these were particularly compounded, if not produced, by the effects of measures taken to protect people defined as medically and legally vulnerable. And as I said, depending on pre-existing vulnerabilities, the effects were compounded. Here you have the experience of a 23-year-old male, Chadian, unemployed, living in a migrant reception centers, where he felt that attitudes towards race made him even more vulnerable in the context of COVID. So he's saying that he was finding it difficult to find a job. And that also made him psychologically feel alienated. We don't do anything, nothing, always at Halfar. That's one of the open centers. I don't understand. All these people, they think we have COVID. They're black, they have the COVID already. People thinking like this. If you give them the CV now, they don't call. Nobody calls and nobody cares, and that's the problem. That's why there's no possibility for jobs now. And but also what emerged in the context of our interviews is the idea of a moral vulnerability. As a result of the effects of the pandemic, people found themselves experiencing what I'm calling here a moral vulnerability. That is a conflict between competing moral imperatives. Morality, which is largely considered within Malta in kinship terms, that is defined according to the obligations and understandings of what it means to be a good parent, a good father, mother, a good child, right? And the measures taken in the pandemic led to certain profound moral conflicts, such as the experience of individuals who found themselves needing to go to work because of the economic imperatives, and yet living with vulnerable relatives and being afraid that they might be the ones to cause them to feel unwell. Or the cases of people who had living with elderly parents suffering from Alzheimer's, and they were very concerned that if they make the parents sick and they're in hospital, they can't visit them and they will die feeling all alone and alienated. So we had these competing moral choices, but also parents who had kids who were born during the pandemic and felt that they were failing as a mother because they're not there with their children who were in intensive care, and they needed to be there to protect them, because this is what it means to be a good mother. So the pandemic forced these moral choices, which led to distress, feelings of guilt, and failure, as well as anxiety. Now, I'll briefly then policy recommendations. So we just focused on 4 preliminary policy recommendations. First, the need to emphasize digital literacy, which is rendered accessible to people living in the residential care facilities. These should be prioritized. And secondly, mental health. Malta released the Mental Health Strategy 2020-2030. This was launched prior to the onset of the pandemic. And we need to go back to this mental health strategy and read it in light of the effect and the known effects of the pandemic, in order to address these issues that have emerged as in light of the pandemic. Greater coordination between the various stakeholders, including the state level, NGO level, needs to be institutionalized through some form of coordinating agency, which does not simply activate in the pandemic, but is already there, ready to be mobilized in pandemic-type situations in terms of future proofing. And lastly, access to green spaces. People mentioned that noise pollution was a significantly, let's say, negative effect on their lifestyle, especially since they were rendered more aware of the need to access the environment, as the possibilities for other kinds of relaxation and entertainment were diminished. So thank you for that. I will now announce the next speaker, who is Dr. Katie Vaccaro from Censis in Rome, who will be joining us remotely.
Good morning to everybody. I am happy to participate to this meeting, also even if virtually, but I think it's a great opportunity to sharing our work. It's very interesting for us to be here today. And I will start with my first slide, please. In which I inserted a brief summary of the points that I intend to treat. But before talking about results of vulnerability assessment in Italy, and more specifically in Rome and in some little towns of Latium, I would like to start with some preliminary consideration regarding the concept of vulnerability. Please, next slide. As you know, the first step of the vulnerability assessment concerns the realization of about 200 of qualitative interviews to people with different types of vulnerability conditions. In this table, you can find the general characteristics of the interviewed people. And in the next slide, please. We can see a table with the main vulnerability categories of our sample. But how did the selection of these 200 people come about? I think this is an important issue. We decided to suggest some starting categories based on our idea of what vulnerability is and what its different expression might be. And we left the selection of new vulnerability conditions to the snowball sampling methodology based on the possible indication of each responder. So in the end, we found 8 new vulnerability categories compared to those initially selected for sampling in red in this table. And we found also several cases, 44%, that have more than one vulnerabilities. Another important issue is that in the 25 of our sample, we didn't find any vulnerabilities, unlike what we expected. And it is important also to underline that new vulnerabilities due to the COVID-19 are present both in group without vulnerabilities and in group with initial vulnerabilities. Moreover, I think that there is a cumulative effect because in a high percentage, 40% of people with initial vulnerability, we found an increase of their difficulties due to the COVID-19. And more generally, new vulnerabilities and increased vulnerabilities are more common among those with more than one. Another kind of snowball effect, a cumulative effect of vulnerabilities. Next slide, please. I would like to give you some example of this multidimensional vulnerability. And first of all, we have a woman who is 40 years old, and we selected her because he is foreign. But her story revealed both the problems linked to the reduction of her income and the problem and some psychological problems linked not only to the COVID, but also to the difficulties of social integration. In fact, in our opinion, vulnerability is a mix of loneliness, anxiety, financial and health problems, as you can see in her quote. Please, the next slide. This is another example of a double vulnerability relative to the disease. Double vulnerability because it is linked both to the chronic diseases and on COVID, And there is another impact of work condition. In this case, the psychological vulnerability related to the COVID are quoted by the young women, but also the possibility that the new work can be considered also as a tool for resilience. The next slide with the last example. The last example of a different impact of COVID on health. In this case, we have a person with a complex psychological experience. He is a phobic, who sees his problem increase because of COVID-19, and not only on a psychological level, because he is a show business worker and he lost his income. It's very interesting in this case, a double effect. There is the worsening of a psychological problem, but on the other side, the lifestyle related to the consumption of alcohol, strongly dependent on external occasions, has changed in a positive way. So a worsening of a psychological problem and an improvement of an unhealthy lifestyle. The next slide, please. These are only a general data, a slide on general data concerning the general impact of COVID on some aspects of health. I think it's important to highlight that there are high percentage of respondents that experience the problem on health due to the pandemic, and these health effects of COVID are also strictly related to the lockdown measures. The next slide, please. And in this case, similarly to the slide we saw before, you can find some data that indicate the impact on work and on income of the pandemic. And it is important to remark that about half of the sample has experienced a change in income due to the COVID-19, and 43% believes that it will not return to pre-pandemic levels. The next slide, please. This slide summarizes some important vulnerability assessment result, in my opinion. A vulnerability assessment that show the linkage between COVID-19 vulnerability and health conditions. First of all, I would like to highlight that the health consequences of COVID, including psychological and mental health, tend to be more severe in the presence of existing health vulnerabilities for people with chronic disease, for people with disabilities. But this is true also in the case of caregivers, for example. Caregivers managing the illness of a family member. Is the same effect. And another important impact of COVID-19 on the health side is the related to the reduction of sociality that creates anxiety and depression. And moreover, is very, very widespread the deterioration of healthy lifestyle for changes of diet, for the lack of physical activity. This is a general effect. I should like to read one quote. With this pandemic, just eating you could. There is, then I was ordering from fast food restaurant a lot in the evening, like twice a week. Next slide, please. Another aspect concerns the link between COVID and other different situations of vulnerability. And I think that economic vulnerability can be considered maybe one of the most important effects of COVID-19. In fact, the more quoted form of vulnerabilities due to the COVID is the economic one. The pandemic has created new poor, and now these new poverty are not covered. And moreover, the consequences of COVID tend to be more severe on those who has previous or intervening economic vulnerability. For example, those who have experienced the employment difficulties, immigrants, or those without a permanent job are more vulnerable. The next slide, please. And another important aspect is relative to the role of other dimensions in vulnerability to COVID. Because this vulnerability depends not only on health condition, but also on income, cultural aspect, and behavior. For example, those who do not follow the rules indicated are more at risk for COVID-19, and at risk are those who underestimate or do not believe in the existence of virus. And in this moment, we can see the same situation for no-vax people, for example. And these are problems related to information and cultural issue. Please, the next slide. I would like to finish with a positive comment concerning the strategic factors for health and well-being. In fact, we found that there is a widespread belief that individual behavior, environment, and social relationship are strategic factors on which health depends. It's a very, very spread cultural attitude. Health is a matter of choice. The environment is very important, but not only the physical environment, but the environment in terms of people around us are very important. These are crucial aspects of our analysis. And in the end, I think that the health consequence of COVID can be considered one of the most important consequences, but also the economic impact of COVID is very, very widespread. And it is important to mention that vulnerability to COVID depends not only on health or economic difficulties, but also on cultural aspects, such as the lack of information or the difficulties in dealing with the confused information about concerning COVID and in general concerning the pandemic. And finally, I think that it is relevant to underline that previous existing vulnerability, that the structural vulnerabilities have a great role in terms of COVID-19 impact, both in social and health aspect. And maybe another thing is important to highlight. I think it's very important to try to understand the destiny of the new vulnerability due to the COVID over time. Are they temporary or not? They can become structural vulnerabilities too. This is another important issue in my opinion. Next slide, please. This is my last slide, and in this case, I would like to subline some insight, underline some insight for an action plan, but starting with a general statement. In fact, I think that if vulnerability is multidimensional, the intervention must be multidimensional too. Not only health and social policies, but also work, environment, and information must become aims of effective action against vulnerability that must involve several actors. Here you can find some examples of these policy recommendations. For example, in my opinion, it's very important reducing difficulty to accessing services in the health field, for example, due to the economic problems. Because I think that it's not possible to improve health conditions without consider the social determinant of health, without consider the social, the economic, and the cultural differences among people. Another important point is shifting the focus from hospital to the community and home-based services, because these services are more effective for the chronic disease, for an aging country as Italy is, and were very useful during the pandemic for a patient treated at home. They represented the real differences in the answer to in the policy for COVID in our country, in the different regional situation. Another point is rethinking responses to the need of elderly. We found that the isolation at home with a caregiver often doesn't work better than staying in a nursing home with a small number of poorly qualified workers. I think it's very important to rethink the general strategy for aging in our country. And another point is improving health information and taking in account different levels of education and health literacy, because the effects of epidemics can be more severe for those with a lack of cultural tools. It is very clear this situation for no-vax people, but especially for people with vaccine hesitation, who can be persuaded in this moment. And on the other side, we have other policy recommendation, more not only in the health field. For example, rethinking the common spaces of the city, and because these common spaces are a great source of resilience. Green spaces and meeting spaces are important for physical and mental health, and also for social integration, for improving human relationships. Another important aspect is to involve non-profit organizations in social and city policy choices. They must have a role in choices, and not only to be supported in their action in favor of community that are very important, often are very effective in the community. Another point is making some emergency solution structural. I am thinking about the financial aid, educational support for precarious workers, for example, during the pandemic, or for people on the edge of the poverty at risk of becoming poor. It's very important that this solution could be strategic, could be permanent. And the last point, in my opinion, is another general point to reduce the gap between protected and precarious workers. Again, new global policies for employment. In fact, I think it's very important to start with a local intervention that can be very effective and very concrete, but it's also important to provide input for a national policy against vulnerability, and it's different and intersectorial different characteristics of vulnerability. Thank you for your attention. And now I am announcing the next presentation from some colleague from Germany. I don't know who is the first. Zelina, maybe.
Hello, it's very nice to be with you here. And so these are our presentation from Munich. First, I would like to give some background information about COVID-19 and Munich. And the first cases of Germany with COVID-19 cases started in Munich, and actually in a very wealthy region of Munich. It's Starnberg, and it's started. The first cases were in an international company, and who had a conference, who organized a conference with Chinese colleagues. And the first cases were the workers of this company and their families. And the second wave of cases were also again from the Munich area, which were very healthy and young people who went to holiday for winter sports in that time. And this means the COVID-19 pandemic started in Germany, in Munich, with the youngest and with the healthy people, and then but in a very short time, it changed the characteristic, and it was the pandemic of the poor and vulnerable people. And we made also this vulnerability assessment, and we had 8 people with vulnerability assessment, but we also made expert or community member or key people interviews. Our main groups were students, international students, and refugees and migrants, disabled people, and lots of characteristics can be included. But we, as my colleagues also said, that they were having the multidimensional characteristics of vulnerabilities. For example, they were asylum seeker, but also disability, and there was one student who was also healthcare workers, but who had drug consume, and he was belonging to a migrant community. And there are lots of examples from them, and also their country of our participants' country of origin were from many different countries. And my presentation is based on questions. And the first question is, why was life much harder for some than others in Munich before the pandemic? And based on our findings, we defined some structural elements and mechanisms that are results of the structures that are making people resilient or vulnerable. And I can start with the resilience mechanisms or structures. As structure, we can see democracy, rights and law and local government. And the mechanisms are that Munich is a green city and it's really safe, and lots of people have access to safe water, and it's family, and it was called by our participants family, child, and disability friendly city. And Germany has a strong healthcare system and social benefits, and it has social services network, and their scientific institutions are respectful, and there are lots of support mechanisms for disabled people, for migrants and refugees, and for elderly people. And in result of this, there is trust, healthy lifestyle, and feeling of wellness. But on the other side, there are also structured elements such as racism and other things that are creating vulnerability mechanisms, such as discrimination, stigma, and violence. And they are not. They are according to race, according to ethnicity, sex, sexual identity, and religion, and etc. But they are not also in community. They are also in healthcare, in institutions, even in NGOs that are for refugees. And insecurity, income insecurity, and housing insecurity is very, very important for Munich. Legal status and job insecurity and working life is not easy for everyone. And the healthcare system was criticized by our participants that it's too class for private and social insurance, and it's market-oriented and Western-oriented medicine. And in result of this, the distrust, loneliness and isolation and stress, worries, and unhealthy lifestyle. And in the middle of them is the individual variables. If the resilience factors, mechanisms are dominating, this doesn't mean that this someone who is elderly or who has a different sexual identity is vulnerable, but if the vulnerable mechanisms are dominating, these individual variables can become a factor of vulnerability. And our next question was that how has the pandemic changed the lives of vulnerable people? And I would like to share some examples of from our participants. The Iman, with her nickname, she is a master's student from Iran, and before the pandemic, she was feeling loneliness and accepting. She had a good connection with the community from her Quran course, but she was feeling some kind of stigma regarding her hijab, and she was having financial problems because of the sanctions and because she can't have from her family in Iran directly money via bank transfer. With the pandemic, all these problems were worsened, and her residence permanence expired, and she couldn't go to Iran, and she had financial problems because she couldn't have money, and she had lots of different symptoms which are related to stress. And at the end, she was diagnosed as Sjogren's syndrome, and she had anxiety of being infected COVID-19 and staying in quarantine. And another person who has cognitive disabilities, and before the pandemic, his life is not easy, but it was okay because he was in supported workplace. But now with the pandemic, he couldn't go to the workplace, and that's why he was feeling loneliness and emptiness and depression. And Turkish lady who has lost 3 years ago her daughter, and had also traumatic experiences during the illness of her daughter with healthcare sector, and the bureaucratic work was very difficult for her, and she has some chronic diseases. But the only thing that was good on her life was the Turkish students who were supporting, and they were calling them Aunt Leyla. Now and she were seeing them as rainbows, but now she can't see them, and the burden of bureaucratic work is very high for her, and etc. And now she has gained access. Her depression level is increased. And the last example is one refugee from Somalia. He's disabled and he wants to access the rehabilitation, but the authorities were saying that he should wait, but now it's almost impossible, and he had to stay in quarantine, and he couldn't do some exercises, which was the only thing that he can do for his instead of rehabilitation. And our next question is, which vulnerability mechanisms were strengthened or worsened by the pandemic? And we can see here some mechanisms that were making people vulnerable before the pandemic, but now they have worsened. Which are there? So violence, people who are losing their job and who are living a crisis in a foreign country that are using this violence, and domestic violence is increased, and also the legal legal problems are increasing, and job and income insecurity and worries, and all the mechanisms, almost all the mechanisms that were making people vulnerable are increasing. But also there are some other new mechanisms that came with the pandemic, such as long COVID, and the main mechanisms, the COVID-19 rules and quarantine and untailored information on COVID-19, and also an epidemic on COVID-19 and the vaccine story, and also, but the other questions, which resilience mechanisms have become more important in the pandemic? And are there any emerging resilience mechanisms in the pandemic? We can see here that there are the support from family, but maybe important from the before the pandemic, but now for lots of families, most of families, the support from the family is the unique or the only support mechanisms, and that the unique Munich is a green city is a very important mechanism now. And also there are some other new strategies or new mechanisms that are like financial support or access to information or COVID-19, the accessibility of COVID-19 tests, personal protective equipments, and vaccination. But the most important thing here, we think that this last question, which resilience mechanisms no longer work during the pandemic. In Munich, there were support and social care for disabled people, for refugees, and for families, and these mechanisms are not working well now or totally stopped with the pandemic. And people lost their trust, and people lost their ability to self-determination, and people who were living in their islands, such as LGBT communities and migrant communities, are alone now. And yes, I can summarize my key findings. And the key findings, we are concentrating on some groups, which is the asylum seekers and migrants and refugees are very important for us. And we saw that they're deeply affected by the pandemic, and strategies applied for the privileged class, applied for the wealthy, healthy, and German class are not realistic for them. We should create some other strategies. And also another important group of ours is the people with disabilities. They experience difficulties due to COVID-19 measures, and the support for them, social support, supported housing, supported working, interrupted due to the pandemic. And the poor ones, the poor disabled ones are affected the most, but there are also some cases who are from the middle income, but they are also became vulnerable with the pandemic. And the mental health is more important than ever, and especially among younger people. And the uncertainty, helplessness, anxieties, loneliness, and isolation caused by the pandemic is the reason of these mental health problems. And we couldn't see, there were some good stories, but we couldn't see we couldn't see any promising resilience mechanisms and very important solidarity stories, unfortunately. And at the end, I can summarize that we saw that the vulnerability triangle, that it's composed of poverty, immigration, and another factor which is very important in Munich, the insecure and unaffordable housing is in the middle of all the vulnerabilities. And Munich is a city for German, for wealthy, educated, and heterosexual people with families. And all the pandemic, all the mechanisms strengthen the link between the poverty, immigration, and poor housing. What are our policy recommendations? Of course, there is a very big list, but these are the most important ones. We grouped it in two categories. To repair the damage caused by the pandemic measures, and to reduce the overgoing threat, and to have better response to the following threats like COVID-19. But we should support people with long COVID, and including providing their job security, and tailored preventive services are needed which are according to the different groups, and ensuring access to all segments of the society is very important. And in deciding the pandemic measures, it should be taken into consideration that the measures should not be interrupted support services for special needs, and mental health services are needed in different languages, especially in Munich, and digitalization in all areas, and accessibility IT equipment and infrastructure for everyone, and IT tools that are suitable for the use of disabled and elderly people. And the last one is the improving the shelter conditions of refugees. But our recommendation is that a stronger fight than before the pandemic with the existing structural elements and mechanisms that are making people vulnerable. And we should construct these strategies from the human rights perspectives and from the equality perspectives and from the social determinants of health perspective. And the one starting point, practical starting point for Munich or for the cities in the same position like Munich can be secure, healthy, and affordable housing. Thank you very much for your consideration. Now I would like to France team and Professor Tamara Wernick is going to present their findings. Thank you.
Just hit right there. Okay, delighted to be here. So I'm just going to cut to the chase here. And I just want to begin by acknowledging the team, the wonderful team that I worked with at Institut Pasteur. So in terms of our results, I won't spend very much time on numbers. We did 109 interviews in the Paris and Seine-Saint-Denis area and an urban area, as you all know. And in a second area, the Territoire Vendomois, which has a population of about 53,000, is primarily agricultural. We also did about 20 interviews with association and NGO actors on the ground. And from the beginning of our activities in February 2021, we have been working with an action and advisory committee, which with whom we are sort of pursuing multi-scalar and sectoral community engagement. 60% of our respondents were here. Whoops, this is not working. I'm sorry. 60% of our respondents were women, 38% were men, 4% were non-binary between the ages of 18 and 95. 62% had a chronic illness, and 53% came from France, 46% came from outside of France. So I want to really focus most of my discussion here on the qualitative analysis. Three initial themes, I think, emerged. There are many more that I'm not going to deal with today, but the first has to do with institutional barriers or constraints on human agency. The second has to do with a loss of confidence, a loss of trust in the French national government and certain professions and the consequences of that decline in trust. And then barriers that French people and other people living in France encountered in accessing aid and assistance here. So one of the initial themes that we identified was, although many different kinds of people were engaging with institutions that were specifically designed to assist them, these institutions rendered people more vulnerable in the shorter and longer term to declining health through massive constraints on their agency. And this interacted with social isolation and profound incertitude. Now, they did so in different ways. So when I'm talking about institutions and institutional barriers, I'm talking about hospitals and those who work in hospitals, those who live in nursing homes and work in nursing homes, those who are engaged in pedagogical institutions, including universities, institutions for those who are seeking asylum in France, and those who are living in emergency housing centers. So these institutions affect and really constrain the agencies of beneficiaries in a variety of different ways. But I'm just going to take one small example, and that is of a nursing home resident. Now, that resident came into one of the nursing homes where we conducted interviews just prior to the pandemic. And really against her own desires, her family decided that they couldn't manage her living independently, although she wanted to remain as living independently. So with the shutting down of all activities and family visits at the beginning of the pandemic in France in March of 2020, really kind of enhanced her sense of abandonment and exacerbated the severe social isolation. At the same time, she was encountering silences around sickness and death that were occurring within that nursing home. So on one hand, she, like other residents, were listening to or watching television, looking at media accounts, constant media accounts of an expanding and very frightening epidemic, and at the same time confronted with silences on the part of the staff. When they asked questions, who's sick, what's going on here, the staff wouldn't respond. And this was a specific policy not to exacerbate anxieties among inhabitants of these residents. But this actually enhances a sense of incertitude among people. And at the same time, exacerbates a sense of feeling abandoned. So with the cessation of all of these activities, these visits and the like, this woman was feeling, a loss of capacity to make her own decisions, a loss of initiative, and a loss of a kind of meaning in her life, to the extent that she said, look, I'm waiting for death, and I hope it isn't too far off, which is really pretty devastating. Now, just so that you don't think that this is an isolated situation, I also want to bring up the example of students who also felt massively derailed, the students that we interviewed, massively derailed by the pandemic, a similar sense of abandonment, a loss of objectives, incertitude about job markets. And, again, I want to emphasize that we would hypothesize that this is really a kind of lost generation, or potentially lost generation. I don't want to overstate this. So the point that I want to make here is that efforts to curtail transmission in France affected those who were engaging with different kinds of institutions that were designed to assist people, but ended up constraining their agency, with the consequence of damaging effects on both their mental health and, over the longer term, a sort of broader sense of their health. The next point that I want to talk about is trust. Trust is really not a thing, well, it is a relationship, but it's also a process that's developed over the short and longer term. Now, vis-a-vis the French national government, and really people referred to the government on the national level, there's a tendency to frame it in terms of an opposition between us and a political class. Some said, oh, well, they did what they could, but they were overwhelmed. Asylum seekers in particular were quite trusting of the government, but the majority of our respondents were highly critical, reproaching the government for incoherent control strategies, reproaching them for a privatization of certain kinds of activities that were normally undertaken by the public sector, from diagnostics to rendezvous for vaccinations and the like. In addition, we found very mixed evaluations of medical professionals. People tended to trust in their own doctors, but had a real mistrust of those who were on television, for instance. And also major complaints among particularly women and younger women about how individual doctors handled their chronic pain, which compelled these women to move into their own, or to seek out alternative remedies for their chronic pain, and had a tendency to promote, we found, mistrust among certain people in the medical profession. Finally, a real mistrust of the media. Many people, as would be expected, complained about the infodemic, about an abundance of contradictory information, really reproaching political class, the media, and those who were appearing frequently in the media. Some responded with a kind of triage of information or tuning out. But one of the consequences that we found was that people tended to recenter on their own family, their friends, their own doctors. But one of the consequences that I think we want to emphasize here is this question of mistrust in both the government and medical professions that came out. These expressions of independence, I'm going to do my own research, I'm going to find alternative treatments or alternative solutions to the difficulties that I have, also meant that some of these people were falling into the sway of anti-vaccination websites, that they may have been less attentive to the government or to medical mainstream advice about how to protect themselves, and particularly vis-a-vis vaccination. So that's something that I think we need to continue to be attentive to. Now, finally, there are many different kinds of aid and assistance at multiple levels that have been offered in France and in multiple sectors. One of our surprising results was that many people did not know what was available, or they didn't use it even when they could have qualified for assistance and aid. That is aid during the pandemic or aid to lead a healthier life. So why was that? We identified 5 different barriers to accessing aid and assistance. First of all, there were those who said, well, they didn't need it. So as one person said, well, no, I know where to get tested if I need to, but I think that if, the aid exists, but when you don't need it, you don't look for it. Secondly, lack of trust. I want to cite the example of a woman who was living in a camp right outside of Paris with her husband and son, explained that she'd been in contact with many associations but didn't trust them. What she said was she'd been in contact with these associations. She said, they don't help. People who live with me go to these associations and they bring back a little food. They take your information, that is the associations, but nobody comes to help you. So help getting your papers? No. I worked with a social assistant for 4 years and she didn't do anything. Third issue is about extreme isolation, not knowing what's available and being so socially isolated that you have no access to that information. This is a situation or a factor that can change over time. So for instance, we spoke to one person who ended up being an asylum seeker, but had been dropped off at the airport and it ended up living on the street in Paris for several months until she was approached by another person who gave her information about an association to contact. And with that one contact, she was able to access an array of assistance. There are also structural problems, and I won't go down the list here. Costly care, the fact that the rural region that we were working in was really a medical desert, waiting lists for mental health, lack of housing, closures of certain kinds of structures during particular confinements. And I just want to cite an example of a 53-year-old man living in this rural Vendôme region with a chronic illness who said, look, with a really serious illness, it's a medical desert here. The doctors, they don't know anything, they aren't specialists. And finally, there are difficulties of asking for help. Fear, for instance, among some without papers, without the official rights to be residing in France, fear of being reported to officials, pride in not wanting to ask for help. And multiple times we heard from informants, I don't have the right to ask for help. My situation isn't so bad. I come from a comfortable family. There are a lot of people who are worse off than I am. And this was particularly striking among, for instance, one woman who was coping with domestic violence at home, who realized that she didn't really, at a certain point, understand what the difference was between what she thought was a generic marital conflict and that it was, in fact, domestic violence. So I want to come back to this figure, and then I'm going to move very quickly on to some policy recommendations. It's clear that these three themes are overlapping, that they influence each other. But one final and surprising commonality that we saw across our rural and urban sites was that we saw less solidarity in neighborhoods and villages even in the rural zones, than we expected. A few people, we had a few examples of sort of neighborhood or village level solidarity, but a lot of people relied on their family and friends if they had them. So yeah, some farm-based exchanges, but really all association activities stopped in the Vendôme area, and in Paris, very little solidarity, mutual aid between people in buildings and neighborhoods. This is something that really, I think, surprised us. And for that reason, we have a number of potential policy recommendations. One point that I want to make very quickly, but I think is really important and has come out across all of the presentations today, is that health is made or broken outside of the health sector. We can't focus exclusively on the health sector to remedy these multiple cumulative interacting vulnerabilities. So, and there are many, many structural issues that I think I've alluded to. I'm just going to mention one major one, which is housing. There is a need, for instance, to make more housing more available to those needing it in the Paris region. Many times we hear housing is there, but it's locked up. It's in the real estate market. A second point may be managing the exodus from among upper and upper middle class people to from Paris to rural areas, which drive up housing prices and make housing more difficult for local people to afford. A second point is about investing in promoting inclusivity and revitalizing communities. Again, that finding that I highlighted at the end about the lack of solidarity. Once trust is broken between people, we need to work to recreate, in effect, these communities and promote inclusivity. So social and cultural activities would be important. Economic investments to promote spatially based solidarities would be important. Building bridges across socially isolated populations using their skills and experiences of different individuals. We talked to many elderly people, for instance, asylum seekers, cultural workers, students who experienced vulnerabilities themselves, but also wanted to contribute the skills that they had. Those are things that I think we need to tap. And finally, I think that we need to promote existing aid and assistance structures. The fact that people don't know necessarily what's out there is, I think, an important issue that needs to be addressed. What's available, where is it available, and for whom? We need to reduce the doubts, the fears, and the stigma around use, underscoring distinctions between equality and true equity. And finally, simplifying the procedure for access to this health, this assistance and aid. Finally, I'm going to turn to a general discussion and invite David Napier and Jens Seberg to contribute some insights here. Thanks very much.
Thank you very much, Tamara, and all of our speakers for your engaging presentations. Can everyone hear me? Okay. Thank you very much. We're going to have a question and answer period, but before that, I'd like to invite, first of all, Jens Seberg to give his reflections on the presentations, and then I will add some comments to that. And meanwhile, if you can put your questions into the chat, once we're done, we'll turn this to Anna Volkman, who will then read out the questions. I hope that's good, everyone. Yes.
Thank you very much. Am I audible and visible? Thank you. Thank you very much. Why is it important to understand these circumstances of vulnerability across large sections of the population in EU countries that we have heard about? One issue, one answer has to do with the nature of a pandemic. We've heard the saying that nobody is safe until everybody is safe. This is true for the global picture and acutely relevant in connection with access to vaccines, but it is equally true within each of our countries. This study contributes in important ways to our understanding of this issue by providing nuanced understandings of the particular problems that people have faced during the pandemic and during the dramatic control measures imposed in all countries. Secondly, in most, if not all countries, a one-size-fits-all approach has guided the implementation of control measures. This may have worked well with majority populations, but this study shows that the approach, however, is insufficient. The ethnography highlights the variation of life circumstances during the pandemic and the overall importance of better understanding the big population groups that are constituted by many different minority groups who have specific challenges that have been overlooked or perhaps have drowned in the process of unprecedented urgency of policymaking in pandemic crisis. The study shows that we need to develop new ways to avoid projecting the normativity of the majority onto the entire population, but find new ways and mechanisms to engage with minority communities and organizations. The imperative of the pandemic is that the needs of communities must be heard during policymaking. This requires new mechanisms that establish more inclusive approaches. Thirdly, health systems are bound by the nation state, but the pandemic is not. The figure of the nation has to some extent worked against international collaboration, but may also have worked to exacerbate othering and alienation of minority communities, hence overlooking particular needs of critical importance, such as, for example, timely and accurate translation of potentially life-saving information into minority languages. Fourth, and without losing track of the intersectoriality and multidimensionality of vulnerabilities, the study also allows for identification of cross-cutting and partially overlapping issues. And just to mention a few examples, the serious consequences for youth across the countries, the risk of losing, as Tamara said, losing a generation during their formative years, ethnic minorities and migrants, access to information, test information and health services, but also other determinants such as housing and work opportunities impact on their exposure to infection. Housing capacity, including capacity to self-isolate. Poor housing conditions make it impossible to protect self and others and to avoid rapid spread of infection among relatives. And individualizing health as a cross-cutting issue. That's a dominant figure in present-day healthcare systems, but in the face of a pandemic, it is counterproductive. We need to destigmatize illness by shifting attention from moral blaming to acknowledgement of the life conditions that place individuals in situations where desirable precautions may be inaccessible. And lastly, and fifth, a lesson seems to be the need to not lose a rights-based approach to healthcare services, as well as a range of other societal resources that impact on pandemic dynamics, instead of a one-size-fits-all restrictions built on fear-based communication strategies. The study shows that a wider range of social sciences can contribute in important ways if given access to policy discussions. This, along with inclusion of minority communities in policy dialogue across tiers of governance, could potentially help prevent unintended negative consequences of pandemic control measures in the future, including the future of the COVID-19 pandemic. Thank you.
Thank you very much, Jens. I'd like to, if I might, give a very brief summary of what I see happening in our program so that we can contextualize our conversation. First of all, I want to point out that this study was brought on as a unique amendment to an outstanding European Commission grant to look at infectious disease outbreaks, antimicrobial resistance, and vaccine hesitancy. So we had to run very quickly with this, and at the same time, our goal is to try to determine what the implications of what our findings are for Europe. So we're, as it were, building the ship as we're launching it to a certain extent. I just want to begin my comments by reiterating something that Anna Voltman said at the very beginning, which is that our goal here is to identify and characterize locally meaningful case definitions of vulnerability, and to bring that which is locally meaningful, that is to say, lived experience, as so far as that's possible, to the level of evidence. And this requires, first of all, as she pointed out, identifying what certain risk factors are, characterizing those case definitions, and indeed oftentimes being willing to be surprised to the extent to which some of the vulnerabilities were the outcome of response measures themselves, to scale up those definitions where possible to larger data sets. And here, I think you'll note, especially in the case of Ketty Vaccaro, who directs research for the Census Foundation, which is responsible for overviewing national data on health for the country of Italy, to see in which ways we can extrapolate, especially within the framework of health and all policies, whatever findings ours are outside of the health sector, to be able to understand vulnerability more broadly and resilience as well. And then finally, to make policy recommendations, which you can see from our presentations that we're only at this point just beginning to do. One of the things that strikes me, however, already about our overall findings is that is the extent to which our teams across Europe are able to demonstrate that thinking about the social determinants is incredibly important. But in addition to that, beneath the visible iceberg are some very, very powerful drivers of vulnerability and resilience, which are oftentimes difficult to measure and therefore not necessarily on the radar of those of us who are dealing with existing data sets, national data sets. And these have to do with, as we pointed out, and this came out especially, well, in all the presentations, but I think Tamara tried to summarize them in her final one, the importance of social isolation, that is to say, the impacts of health inclusion and exclusion and what drives that, the effects of social trust and mistrust, and the problems of building trust once it's lost, a big challenge for policymakers who themselves are vulnerable to divisive constituencies that don't necessarily subscribe to the recommendations, good though they may be. And then finally, a lack of agency, what we oftentimes in our work refer to as time poverty, where COVID-19, if it's 8th, 9th, or 10th on your list, because of the level of calamity coping that you're engaging with, might be surprising, and indeed it may not be on your list at all. The extent to which what we characterize as the problem may not be evidenced as the problem by the people who are living with the threat of COVID-19 in their daily lives. And what's emerging for us, and I think this is one, to me, very important take-home message, is that indeed these may actually far outstrip better known indicators as drivers of vulnerability and resilience. So here I think we can't overemphasize how important it is to remember that vulnerable populations may have sufficient compounding risk factors not to be able to engage in behavior change at all, and that indeed we may define a vulnerability resilience threshold as that point at which it becomes difficult, challenging, if not at times impossible, for people to become the agents of their own health destinies. This, I think, comes out over and over again in the things that we've evidenced in our work. And I really want to thank all of our presenters, and thank you all here for your time and listening to us. And Anna, do we have questions in the chat that I can turn to you to read out?
Yes, we do.
Yes. Yes, I would like to answer the question, or I would like to begin to reflect upon this quite important question. It's
repeat the question.
So it is the question about heterogeneity. The question was about heterogeneity, how to understand and reflect heterogeneity inside the policies. So, the question was, have you come across any policy mechanism that capture intersectionality in European countries? This is really, really important question, and I'm really sorry I don't have any I didn't come across such mechanism on the level of European countries. But I think that the first step here is what we are doing today, and maybe in other occasions also. The first step is really to understand what is going on the local levels, and to do a research that is open to new vulnerabilities, that is open, that is not looking through static and rigid ideas that were in the past quite important, and that we after a research that is based on field research and also in other ways, but also field research, only on this basis we can then think of different mechanisms. Maybe somebody else would like to add something, please.
So we have a question for Tamara. Yes. So Peter Binsler-Iverson says, can we, or how can we learn from or apply the concept of syndemic or synergetic epidemics to guide the discussion today? Seems like the last presenter from France addressed this dual perspective. So maybe you want to follow up on that, Tamara?
Can you all hear me? I hope so. I actually think, Peter, that all of us were addressing this notion of syndemic or synergistic epidemics, particularly in our understandings of vulnerabilities, not vulnerability, but vulnerabilities as multifactorial. And so, I'm thinking about, for instance, some of the figures that, for instance, Ursula put up from Slovenia, what we saw from Germany as well, in addition to the results from France and other countries, that we need to think about these factors contributing to vulnerabilities as interactive, as cumulative over time, that can have certain kinds of short and long-term health consequences. So I think that this is very much along the lines of what all of the teams have really been thinking, and hope that answers your question. I think there's another. Does anybody else want to add to this? Okay.
Yes, actually, we have a great sound effect. Okay, we have another question. Of course, there's actually many, but I have someone with the surname Story says, thanks for the presentation, such important and interesting work. To build on Iliana's question, I would also be interested if you have found some examples of policy interventions which have successfully built trust in the healthcare system across the respective countries, and that will be answered by Professor Baldacchino.
Hi, thanks. So I guess I'm not going to give you an example of a policy solution, but what we found on the ground in terms of trust. And I think this wasn't just common in the Malta side, but we're only now building up the comparative analysis. But people reported trust in local medical authorities. So basically figures like their personal GPs or the local clinic to which they go to which they have a direct and personal relation. while they might not have expressed that level of system-wide trust, but trust was built on individuals and on this personal relation to individual healthcare providers. So this begins to sort of orient us towards understanding how we can build upon that trust. And during the pandemic itself, what we found in Malta, again, building a personal relation between the superintendent of public health as an intimate daily figure one gets to know, built that trust. Although, of course, then that trust begins to be challenged once you start having a conflict between the political classes and politicians versus medical authorities. So once the two systems are seen to be at loggerheads, that trust was eroded. Whereas we also found not so much in terms of trust in relation to international health authorities, including things like the WHO, where initial advice was seen to have been contradicted regarding usage of masks and so on. So people perceived that given that advice changed, therefore the authorities are less trustworthy. But this did not erode trust in terms of the local physicians. So that's, I think, a good indicator for us to help understand how we can possibly design forms of policy interventions that build upon that trust and scale it upwards. Thank you.
Okay, great. So it looks like for the final minute, even I'm managing the technology here. So I have a comment I have a comment from Zilish also following up on this.
Yes, now it's open, I think. I can also make some comments regarding Germany and the scientific institutions. At the beginning of the pandemic, the scientific institutions were very trustful, and I think that people didn't lose their trust to scientific institutions such as Robert Koch Institute, and the transparency of the results and of all the data was a very important factor. But at the beginning of the pandemic, people were also having trust to the government, but then in the second phase or in the third phase, they are started to lose their trust when their financial problems and all the burden of COVID-19 measures were very high for them. They were also trying to lose their trust to government, but also, another factor that the accessibility of COVID-19 tests, that everyone can have COVID-19 tests for free, was an important factor for Germany.
Thank you, Zil. I have a question for Tamara, which relates to vulnerability differences based on gender. Have you noticed anything in that regard?
Okay. Hi, Carrie. Yes, I mean, gender is fundamental. Gender considerations are fundamental, I think, to all of our studies. But just to sort of reiterate one of the findings we had when I was talking about our findings concerning trust and the ways in which a number of women, particularly young women, were talking about the mistrust of healthcare providers who didn't take their concerns about chronic pain seriously, encouraging them to go out and look for alternative forms of treatment. In other studies, I think outside of this vulnerability assessment, we've found, particularly with respect to the Recover project, that vaccine hesitancy among women tends to be, in France and in other European countries, tends to be higher among women than among men. So just as an example, one wonders whether relationships between, for instance, women and healthcare providers and perhaps the erosion of trust that's occurring there has, in effect, fed into concerns about vaccine hesitancy and resistance among certain groups of women not to accept COVID-19 vaccination. So that's just an example, but I think that this is a set of cross-cutting findings, and so we weren't able to go into a number of these things, these concerns in quite such detail. And I know that a number, for instance, in Germany, there was a discussion about, for instance, trans people experiencing disproportionate burdens of social isolation and stigmatization, even in the context of the pandemic and pandemic restrictions.
So, if I may just very quickly, I would like just to add something from our study in Slovenia. It was really clear from many interviews that we witness retraditionalization of women's role in many cases when, for example, measures of stay-at-home measures. In many cases, women reported that they were just automatically been assigned the role of a cook, of mother, caregiver, who is all the time engaged in the education of the children. So I think many measures, at least in Slovenia, shown how this retraditionalization of women's role were really present.
Thank you. Thank you very much, Ursula. And I have a comment that I would actually want to throw to David, which is, I'm sorry, I'm scrolling through. So actually referred to Ursula's presentation, but there's Blandine who says vulnerability assessment in Slovenia, but then I agree to the distinction between vulnerability by COVID infection and vulnerability created by measures. I think it is the same case in developed and low developed countries. This means that the problem is not in the performance of health systems, but in the public health approaches of COVID. What do you think about that?
I think that it's a really very powerful lesson for all of us. That is to say, the way in which we've characterized COVID as only a biomedical problem has had extreme knock-on effects in terms of its impact on populations and the effects it's had not only on helping us rightly to implement measures that will protect individuals from biological threat of a highly infectious virus, but also the degree to which it sensitizes to the fact that we really must take the health and all policies agenda quite seriously. And that is to say, think about the health impacts of our decision making in every area of government and policy making if we're somehow going to avoid the kinds of created vulnerabilities that emerged within the context of COVID-19. And these not only are effects on populations that are too powerless to represent themselves for whatever structural reasons, but also in the long-term effects of what we'll be living with, not just in terms of long COVID, but also in terms of what we're now seeing, which are significant mental health consequences that are caused not only by COVID itself, but by the strategies that we've implemented to deal with it. And there's a lot more we could say on that. And I would suggest that we have a separate seminar on that at some later point once our data is further analyzed. But I would like to thank everyone here and turn this over to Tamara, who is the lead of this work package for our program, to have the final word.
I'm almost afraid to turn on my microphone for the feedback. Sounds like we're in a rock concert, not in a symposium. I'd like to, first of all, thank the European Commission for funding this. It's been a really, I think, remarkable experience for all of us, and particularly during a pandemic, during multiple confinements. I would like to thank all of you for attending this. I know that we didn't get to all of the questions, but feel free to contact us offline. Joelle, for instance, I see your question and I started writing an answer, but you can get in touch with all of us, and we're really happy to respond. I'd also like to say stay tuned for additional findings, additional reports, which will be public access. That are coming out of the individual countries and coming out of a sort of more global perspective. And again, thanks very much for these fabulous questions. They made us all think, and we wish you good health and a good day.